The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Cancer Update, a short walk through a long journey. Glad that everybody is here listening. The number here at KAAM 770 is 972-445-0770, and the toll-free number is 877-272-5226. With me today is Ms. Tina Withrow, THOC's patient navigator. Tina?
Hello. You guys only thought I wasn't going to be here today, but I'm back. Anyways, I hope everybody's having a good afternoon. Got lots of things we're going to talk to you about. I've got a couple of questions for Dr. Birnbaum. The first question I want to talk about is triple negative in breast cancer. Dr. B, what makes that so aggressive, and what makes it so hard to treat?
When a woman, even a man with male breast cancer, can have this also. You go through the tissue diagnosis, and they come back and they do the estrogen receptor, progesterone receptor, and the Herceptin or HER2/neu tests. Over the years, studies have come out, statistical studies where they take people who are ER or PR positive. And don't forget, HER2/neu has not been around that long. And they do these examinations, histological evaluations of the patient. They look at the size of the tumor, whether there are lymph nodes that are positive or negative, whether there is lymphovascular, meaning lymph tissue or vascular tissue that is lymphovascular positive or negative. The Ki-67 histological test, whether what its number is at a certain level, the higher its number goes beyond a certain point, the prognostic indicators are worse. Whether there is perineural, meaning nerve sheath involvement. So you have a wide parameter. But they narrowed it down to the PR and ER, progesterone receptor, estrogen receptor, and HER2/neu, Herceptin, as to whether or not they are positive or negative. There are some other parameters that we did not talk about. There's premenopausal, postmenopausal, and the perimenopausal, 2 or 3 years on each side of that period of time. And each level, if you're diagnosed during those certain periods of time, this is all statistics, have different results, long-term results. Studies have shown by a multitude of institutions, from MD Anderson to Sloan Kettering, from the San Antonio program, Mayo Clinic, that triple negative, especially in premenopausal women, has a horrible prognosis. They've even got studies out there that show that triple negative premenopausal women have over a 45 to 50% increase in incidence of brain metastases as one of the primary sites in breast cancer women. Why it's this way, it's strictly research that is done. They took these women over a 5 to 7 year period of time. They took women who were ER, PR positive. They broke them down by the age group, by the menopausal cycles. And then they took the same group who were HER2 positive, ER negative, HER2 negative, ER positive, PR positive. The whole, you can just go through the ramification. I think there was close to like 18 different parameters you use. And the one that had the worst prognosis, whether you're premenopausal, perimenopausal, or postmenopausal, was the triple negative patient. They had the highest increased incidence of recurrence. What does that mean? That means you need to watch these patients. You go through same treatments as you would with the standard patient. However, you can't use Herceptin because they're HER2 negative. So it's going to limit some of your treatment modalities. You're not going to use anti-estrogen, anti-hormone therapy because they're ER/PR negative.
That would be tamoxifen or some of those.
Tamara, Arimidex,
Aromasin,
the new drug Ferriston. So you can't use those drugs. So it's basically a chemotherapy-oriented protocol that they're going to be using. There may be some EGRF inhibitors that you can use, some VEGF drugs. Some of the latest literature is going back again. We know one of our programs about 4 or 5 months ago, they took Avastin off the market for metastatic breast cancer. Now some of the latest literature is coming back out saying, well, we've gone back and done some more studies and maybe we should start including Avastin because the overall survival rates do show improvement. Before they said the overall survival rates did not. But going back to your original question, the triple negative patient now, they're saying needs to be watched closer. The standard patient, while you're on chemotherapy, I use the MD Anderson guidelines that every 2 to 3 months we do a staging workup, x-rays and scans. And once they finish therapy, I do it every 3 to 4 months the first year, every 4 to 6 months the second and third year, and every 6 to 12 months the fourth and fifth year, and then once a year thereafter in people who were treated with chemotherapy for breast cancer. They're saying now in the triple negative patient, not only should you do it more frequently, but you must include MRI or CTs of the brain because of the high incidence that triple negative has for brain metastases.
It also does for liver mets too, doesn't it?
Yes.
So, yeah, it's one that you've got to watch close. So when you're saying you got to watch somebody closer, somebody on standard treatment, are they going to get scans every 3 months or 2 months?
If they have metastatic disease, I do it about every 2 to 3 months. If they're just standard protocol without metastatic disease, be it neoadjuvant therapy, I do it every 3 months.
So then,
while they're on therapy, once they're off therapy, then they don't need it as frequently.
But for
that includes blood tumor markers.
Okay, so for a triple negative, would you do it closer than that, or you can't do it like every month because then you don't notice any changes? Is that correct?
No, not at all. But you run into the thing that you've got to use is you've got to use some of your own, judgment. If you've got a patient, you started therapy, and 6 weeks later they come in and they're complaining of a lot of headaches or dizzy spells, or you got to be worried that maybe they got a brain met if they're a triple negative, or if they've got totally new symptoms, and you're treating a patient, whether it be breast cancer or any type of cancer, and they present with new symptomatology, you owe it to the patient and you owe it as far as being good in clinical evaluation to do the appropriate studies. We have to do, like I said before, peer-to-peer all the time. We just got through with scans on a patient, and now they have new symptoms. You got to order up the x-rays again. You're going to run into the insurance company that's going to say to you, hey, we just did this. What's the reason? You got to take the time to explain to them, well, they got all these new symptoms. And let's say you did some blood studies, and now their tumor markers are a little bit higher, and they're on treatment, which you would not expect. You've got to go try and fight the case for the patient and get these studies done because you just can't guess.
Along the breast cancer, we've been talking about breast cancer. What percentage of your patients end up having lymphedema or swelling problems?
Wow, I would say 20%, maybe 25%, because of axillary dissection and removal of lymph nodes. They end up with some form of lymphedema, some worse than others. Obviously, it is more contentious if the patient is a heavy-set patient from the beginning, an overweight patient, has large skin folds, large arms, they're going to be more difficult because the surgeon's got to cut through a lot of tissue. And in doing so, no matter how skilled they are, you're going to run into that risk factor. And it is almost as difficult as the disease itself because there's some macerations and cutting, and it just happens. They get this lymphedema, these swollen arms. And the late Nylene Eccles, a real tiny little curmudgeon lady, brilliant lady, was one of my professors at MD Anderson, and I'll never forget one of my fellow doctors who was doing a fellowship with me in the medical oncology breast service. We were rotating our 3 months on breast service, and it was our first experience going through the lymphedema clinic. And Dr. Eccles was walking down the hall and just walked right by this lady, and the doctor said to Dr. Eccles, what would you recommend we do here? And she just looked at her straight face and said, cut it off. Says it's not going to get any better. Lady almost just passed out right there. And that used to be one of the standards of treatment, because when you have horrible lymphedema, just horrible, it is continuously infected. Some of them become gangrenous because you block off, with that severe lymphedema, you block off the circulation. So you get clots, you get infection. It is just
painful.
Gangrenous and painful.
I know now they teach lymphedema massage, that you can do that yourself. And
well, don't forget, that was many years ago, over 30 years ago, when I was at MD Anderson.
Oh, I thought it was the early 1900s.
It was 1865.
1860.
I won't say what I'm thinking.
All right.
But anyway, the swelling is just unbelievable. I think over the years, the techniques by the competent surgical oncologists, you're not seeing as much lymphedema. That's why it's real important, whether you be male, but mostly females, obviously, because they're more common to see the breast cancer. You make sure your surgery is done in the hands of a competent surgeon who has the experience in doing breast cancer surgery, because there's more to the surgery than just a lumpectomy or just a mastectomy. You're going to do axillary dissection, and you're going to have to get those nodes. And you got to make sure that the surgeon that you pick is well trained, has a lot of experience, because the lymphedema is a crucial part, especially if you're an overweight or heavy person, big person. You can expect you're going to have problems. I'm not going to try and make this light of the subject. You're going to have problems if you're an overweight, heavy person. You're just going to. I've yet to see it, that it didn't happen that way. So, but fortunately, I would say in the last 5 to 6 years, there's been such an improvement in the surgical techniques and the post-operative techniques that you jump on it immediately. I mean, there are companies that their only business is for lymphedema. They're trained people there, like nurses and techs, that deal strictly with lymphedema. They have lymphedema clinics where you go in and, like you were talking about, lymphedema massage that reduces the swelling. Once you get that swelling out of there, the chances of infection and problem are minimal, and it just it makes it a lot easier to take care of. But it's a serious problem you run into.
It's a life-changing event when it happens. I've seen people suffer greatly from it.
Oh, well, I will tell you, I've seen people go into complete remission from their cancer, and their only problem is this lymphedema. And it's something, that's why, you want to make sure that you're in the right hands. And
I've heard that you can get lymphedema also from having the lymph nodes radiated. That can block that. I don't know if that's true or not. But
it's true, but I don't see that as frequently. The most changes I see in lymphedema are usually in the patients that undergo surgery, axillary dissections. Now, those who undergo a lumpectomy with axillary sampling don't get as much lymphedema as those who go underneath a radical mastectomy with axillary dissection. But again, I'm not a surgeon. It'd be good to talk to the surgeon, whoever you are. We just had a young lady come to our office this week, and she was an adorable young lady, thin as can be. And she had a mastectomy. It was her choice. She was given the offer of having a lumpectomy with axillary dissection versus a mastectomy. And after consultation, she went and had it done, and she has come back, and she is ER positive, HER2 positive, and her tumor was 3.5 to 4 centimeters, so she's a candidate for therapy. And it would be extremely unlikely that she would have problems with lymphedema because how small she was. And she didn't have any problems, and she was treated by an excellent surgeon, a very experienced breast cancer surgeon, a lady surgeon, and did a superb job on her. So, again, it depends on who your surgeon is. Number two, even if you are a large woman in the hands of a good surgeon, an experienced surgeon, it could make a dramatic difference in whether or not you get any evidence of mild to severe lymphedema. But I will say this, jump on it immediately after surgery. Get it taken care of. Don't let it fester.
Along the lines of breast cancer, I know that there are statistics out there, and I want to know what you think about this. I personally, if I had breast cancer, I would have a double mastectomy. Not only that would be a gift for me with my big chest, but seriously.
Am I listening to this?
Yes, you are. But seriously, there's something about having something cut out that I think would just give you more of a peace of mind. Just saying, okay, I had cancer in that breast. I don't want cancer in the other breast. Take them off. Let's do reconstruction.
Okay. Statistically, we know in breast cancer, if it's going to spread, at least 18 to 18.7% will go to the opposite breast. That's a given. That's been a known statistic for years. I don't know if I totally agree with you, but it's a personal thing. There's I think a lot of it would deal with getting the BRCA. A lot of it would deal with having family history, and you obviously have a very strong history of cancer in your family.
Yes, my brother is just, in addition to his other cancer, he's got head and neck cancer now, and he's not going to do treatment. So, yeah, it's there in the family. He's not treating it at all. He's just he's too sick otherwise to have anything.
Well, so there are a lot of parameters I look at. If I see a woman come to me and they don't fall into the high-grade criteria and the high-risk criteria, I'm going to go for the most minimal amount of treatment. If I can get by, statistically, we know that a lumpectomy with axillary dissection in certain types of breast cancer is as good as a mastectomy. I'm going to try and not force, obviously, but convince my patient that's the way to go from a statistical point of view. If we've got other issues involved here, if we've got the tissue shows high Ki-67, if we've got some inflammatory changes, if we've got different parameters that are negative, histological parameters, I'm going to tell them that I think a mastectomy is the way to go. And that's what I'm going to recommend, that they go that route. Having the opposite breast taken off is really a personal thing. I look at it from a point of view whether there's family history, what the histological type is, what the histological findings are, lymphovascular invasion, the other parameters that we talked about, and I would have no problem recommending doing bilateral mastectomy. It's no different. And this goes, maybe I'm just, it's the male chauvinism in me, but after being in oncology a long time, I really think that most women should have their uterus removed.
That was going to be my next question to you.
Because after childbearing years, you are having occupied your body an organ that is second, third highest on women in getting cancer. Uterine and endocervical cancer. I'm not saying take out the ovaries. Don't misunderstand what I'm saying. But I think in those women who are not going to have any more children, and the procedure is so simple today, you can do laparoscopy hysterectomies, you're eliminating a high risk, especially if you have a family history of cancer, not uterine cancer, just a family history of cancer. You are eliminating a very major area.
Life-threatening
without a doubt. We have patients now that had uterine and endocervical cancer, and it's come back, and it is a devastating disease. This patient has just gone through hell in treatments and radiation more and more treatments. And could it have been prevented had she, after her last child, and she wasn't going to have any more, hadn't had the hysterectomy? I think the chances are statistically in her favor. She would have never gotten this cancer had she had it removed. And I don't see why, again, I'm talking from a male point of view, and it's a personal thing. It's a woman's thing. I don't see why you need to keep an organ that has such a high propensity for developing cancer at later years.
I agree.
That's the only reason why I would bring that up. And it's the same thing doing a double mastectomy because of the increased incidence and risk factors involved in it. And, it's just I'm sitting here thinking about this. I cannot think, somebody on the other side will say, well, that's a male chauvinist thing. Why don't we just, why don't we do an orchiectomy on a man if he's not going to have children later on? There may be some talk with that too, because of after you reach a certain year, the high risk of getting prostate cancer, very low testicular cancer in the older age men. That's usually in younger individuals up to age 50. After age 50, 55, prostate, and doing an orchiectomy, removing the testicles.
I can just see it lining up down in the Fort Worth stockyards. We could reduce the incidence of cancer.
Somebody could come back and say, well, if you're willing to do that to women, why don't we do that to men?
I know a few women who would like to do that just regardless of the cancer.
It's not a gender question. It's a question about self-preservation. But, going back to the original topic about, you mentioned you would have a double mastectomy. In your case, I would probably agree because of depending again on the histological presentation, if God forbid you came down with cancer, depending on the histological presentation, your strong family history for multiple cancers, I would probably recommend, I would agree with you, I'd get a double mastectomy.
The next question that I have for you involves when you have a cancer of unknown origin. And how do you make the determination that you're just got to start somebody on some kind of, somebody comes in and they haven't been able to find it. They know it's cancer. It looks like cancer, walks like cancer, talks like cancer. They're having all the symptoms of it, but sometimes it is a bit of a needle in a haystack getting a biopsy. What do you do in those instances?
It's interesting because I just read some articles this morning about unknown cancer, and it is becoming more prevalent. It used to be 4 to 7%. Now it's in double digits. People come in,
and they seem to be very sick by the time they get to you. And
a lot of them. The most I've ever seen of cancers of unknown origin are the neuroendocrine tumors. So those are slow growing. They're not as aggressive. But we've had some patients recently that came in and they had a tissue, a bump. It was not a melanoma. It was a male. It was not a colon that had spread. It was not a lung cancer. It was not a squamous cell or basal cell of the skin. It was a cancer of unknown origin. I can't mention his name, but we had a patient a long time ago, came across the Oklahoma border, and he initially was a unknown primary, and we treated him. He came to us with liver mets. His whole liver was engulfed. And we gave him hepatic artery perfusion and put him in remission, and he lived quite a long time. And he came into the emergency room one night with abdominal pain, and they took him to surgery for an appendectomy, and they found the tumor.
Oh, they actually were able to say, okay, here it is.
They eventually found the tumor. When the tissue from the appendectomy was taken to pathology, they found the cancer cells. So
how do you work around insurance on that?
Insurance knows about unknown primary.
Okay, so there is a diagnosis code.
It was one of the executives with Aetna that had an unknown primary.
Oh, okay.
So they're aware of stuff like that. But it is a fascinating disease. from an academic point of view to treat. There are just there's not a lot of drugs out there that have been shown to be very effective. Usually a combination chemotherapy regimen, sometimes utilizing radiation therapy, depending on where it is and what it's happened. The most common I ever see is somebody comes in with a lung mass, and they do a biopsy, and it is not compatible with lung tissue. It's coming from someplace else. Is it from the kidney? They just don't know. And we send it special stains off to Caris in California, or we send tissue down to MD Anderson, or we do special studies to Genoptics or special lab studies. It just goes on and on and on to try and find. Everybody's going to come up with an opinion as to where the primary is. And it's from an academic point of view, it's challenging. From a treatment point of view, it is just can become relentless, because you've got to be very aggressive, because
it seems to take hold very fast of the patient.
If it's not a neuroendocrine-based tumor, then it's going to be a very aggressive tumor. And you need to come up and do the research with every type of protocol out there. And there are certain institutions, I don't remember, I think there's one in Philadelphia, Fox Chase, that have programs that are guided towards unknown primary types of tumor. So, but you have to be aware of it.
Explain again to me about cancer cells. How many cancer cells does somebody can they have in their body by the time they're diagnosed? Because I think that's fascinating.
When I was at MD Anderson, a lecture was once given, and it fascinated me, that everybody walking has cancer cells. You, me, everybody. The difference is that there is some type of chemical stimulation. Something stimulates those cancer cells.
To turn on?
Right. Those anaplastic cells to become aggressive. There was a study done at Guy's Hospital in London on people who...
There's a hospital by the name of Guy's Hospital?
Oh, famous hospital. Great hospital. It's
Do they have a girls' hospital, women's hospital?
No, it's Guy's Hospital, and it's like Parkland is to Dallas.
Oh, okay.
And phenomenal hospital, great research hospital. And they did just random on people that had died, came in through their emergency room, died in the ER, they did autopsies on. And they found in over 68% of the cases, patients who with no known diagnosis of cancer had cancer cells. So whether it takes one cell or a million cells, something has to stimulate those cells, whether it be environmental factors or chemical factors, I don't know. But something stimulates those cells to become metastatic or cancerous and start growing. To put a number on it, I could not say that personally. I don't know that. How many cells it takes before it becomes obvious. We know in doing tumor marker studies and biopsy studies, you have microscopic cells, as opposed to those cells that become growth and start growing and become macroscopic, where you can either feel them or they show up on x-rays. There's a big difference. It's the same thing that you say. The woman study was done years ago on women who take a shower and find their own lump rather than going to a doctor. The study said that women who find their own lump that proves to be cancer have about 1 million cells and less than a 20% chance of being metastatic if they find it themselves. The woman who is a little bit more negligent, doesn't do her routine examination, doesn't do her mammograms, decides to go in and see her doctor, and her doctor finds this lump and then does the studies, has greater than a 60% chance that it's going to be metastatic and has over 1 billion cells.
That's just astronomical. That's kind of mind-blowing.
It's just a little bit different in the presentation. We are going to take a short break. Everybody come back at Cancer Update, a short walk through a long journey. The number here is 972-445-0770.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Dr. Dennis Berenbaum, cancer specialist. This is Cancer Update, a short walk through a long journey. The phone number here at KAAM 770 AM on your dial is 972-445-0770. The toll-free number is 877-272-5226. We're going to talk about some things that are going on in literature that has come out, and I found this to be most interesting. This comes from Oncology Times. This is the September issue put out by Dr. Ezra Cohen. Dr. Cohen is from Associate Professor at the University of Chicago Comprehensive Cancer Center. Grapefruit juice increases bioavailability of an mTOR inhibitor. mTOR inhibitor is a certain type of drug.
What does bioavailability mean?
It means that it's easily more absorbed and taken into the system and active in the system.
Kind of like the
has a better cell kill percentage.
Okay.
So this talks about grapefruit juice is known to interfere with the metabolism of numerous drugs, and patients on these drugs often are warned to avoid different fruits. Now, researchers at the University of Chicago have found a way to turn that disadvantage into an advantage for the drug sirolimus. Sirolimus is a drug, temsirolimus is a drug, Toracel, that's used in metastatic renal cell and used in adjuvant renal cell kidney cancer. But what's important is to listen to all this and understand what is going on. If optimized, the approach could reduce drug costs for a wide variety of oral cancer drugs. Remember, in the last couple of weeks, we've been talking about oral oncolytic drugs, oral cancer drugs, how the shift in the parameters of treatment of cancer today has gone from always being IV chemotherapy. Now there are more and more new oral agents out there that are better absorbed and are available rather than using IV therapy. What has been perceived as a problem of drug-food interaction, we really saw as an opportunity to enhance the bioavailability of this drug, because we know that very little of it actually does get absorbed, according to Dr. Cohen. There is no doubt that the development of these ideas is going to cost something. But if we look at it in the context of how much these drugs cost now, you see the cost savings quickly begin to be realized once the clinical trials are done. They showed in combination, they did it, the drug by itself, the drug in combination with an antifungal drug called ketoconazole, and the drug used with grapefruit juice. With ketoconazole, you were able to reduce the amount of the drug required because it improved the bioavailability. You were able to reduce the amount of drug required by 500%. In absolute terms, the once weekly dose required to reach the target amount needed in the body in taking this drug, sirolimus with ketoconazole, was 16 milligrams. 25 milligrams was required for patients taking sirolimus plus grapefruit juice. And if you took the drug alone, you had to take 90 milligrams. They showed in these studies that many oral cancer drugs can cost as much as $5,000 per month. With this, you have the potential to reduce the amount of drug needed by half, and in some cases, using this drug sirolimus and grapefruit juice, you can reduce the cost by 70% of the amount of drug that you have to purchase. And a lot of times the insurance company is not able to cover this in many policies. So what they're showing is more and more research is being done on the bioavailability, which brings me to the next topic, which was just out of the ASCO Post in September of this year. The National Institute of Health is facing a significant budget reduction in January 2013 due to the automatic across-the-board cuts known as sequestration. We're all listening on TV about the political presidential race right now, and during that period of time, after the presidential election to the time that the new Congress is put into office, there is a gap in there, that period of time. And the sequestration, where they're going to cut the budget in defense across the board, is also going to be a $2.4 billion cut in the NIH funding. This will also affect research which is supported by 432 jobs in the United States.
That's pretty significant when you're talking about cutting funding to the NIH, because that's where you get a lot of progress.
Oh, that's
in the
where
treatment.
The majority of all the cancer research. From Dr. Sandra Swain, who is the president of ASCO, the American Society of Clinical Oncology, sustaining the nation's investment in cancer research is critical to our future. We can't afford to lose ground to a disease that touches nearly every American. Congress must understand that cuts on the scale being discussed could significantly slow the pace of scientific discovery, hurt local economics, and most importantly, delay new cancer therapy for thousands of current patients and future patients. Cancer survival rates have risen steadily in recent decades, and quality of life for patients has improved dramatically. Much of this progress has come from the critical NIH-funded research. By losing this funding, the ability to come forth with new drugs, for example, the research being done on Avastin, they went back and they're now doing more research on Avastin. Part of that is the NIH research. If we find that that drug is as good as they thought it was, it may improve survival, may improve quality of life by over 18 to 20%. Well, you take 1,000 patients, 20% of those patients, you're looking at 200 patients that are going to have improved survival and improved quality of life. What is that worth?
I agree 100%. The other danger is that insurance companies tend to deny things, and without grants and without funding to look at these different types of drugs, it's going to allow insurance companies to say, no, we don't have evidence that works. And the drug you were just talking about, Avastin, is really pretty living proof about that, because they brought it out on the market. It was used for breast originally, right?
No. Avastin originally got started for metastatic colon.
Okay, so metastatic colon.
And then it went to lung, and then they found it worked in breast. Now they use it in metastatic kidney cancer and in melanomas.
But for a while it was they pulled it, brought it out, pulled it, brought it out. And don't you think that had to do, that the reason they pulled it and then brought it back out was specifically from people doing testing and from our researchers showing
Well, when they took it off the market, if you remember, I guess maybe a year ago, it was national across all the TVs because it was one of the hottest drugs being sold. And I believe it's Genentech that puts it out. Their stock went crazy. The drug was phenomenal for colorectal, but then they got it to breast cancer, which is your number one cancer. I mean, there's no more greater recognition of any cancer in the world today than breast cancer. We're right now in Breast Cancer Month in October.
I know all the patients that don't.
Every football player is wearing pink socks and pink hats.
And every patient that doesn't have breast cancer looks at me and says, "Why couldn't I have breast cancer?" Because they just get so much more recognition on TV with celebrities and so on. It's really heartbreaking that we don't support some of the other cancers that are out there. But, I love breast cancer survivors as much as all cancer survivors.
Well, going back to the discussion, when they took the Avastin off, this really disturbed a lot of institutions, not even the institutions that were doing the original research. A lot of oncologists said, wait a minute, I'm not part of this research grant. I'm not part of the population that they're studying, but I can see I've got 30 patients and, my patients are doing better. I'm getting better response rates. I'm getting better survival. I'm getting better quality of life. So when they took it off the market, you use it at your own risk. Some insurance companies will still pay for it. They're very far and few between. The other ones won't, and it's a very expensive drug.
Will the price of that eventually come down, Dr. B?
I think over time it will, sure. I think it will over time. But the point
It is
here,
not an oral drug.
No. It's intravenous drug.
It's an intravenous drug, and because it's so new and because of the...
Well, it's not new in the fact that it's been with colon cancer for 5, 6, 7 years now.
You'd think that long the price of it would come down. You'd think that they would cut you a break on that, Because I know some people who are buying it off-label. I have some people.
There could be a lot of danger in buying it, brown bagging it as to its efficacy.
I know 2 people right now that are paying cash for it.
Well, I've known some patient who went across the border, both to Mexico and Canada, to get it. I will not administer those drugs because I'm not sure of the quality of the drug, and I don't want to be responsible for that. And it's just my personal thing. I do know some doctors that will. Who are out in private practice. I do not know any major cancer institution that will do that.
I don't either, but I know that it is being done. And look at what we're seeing with the injections and the meningitis outbreak. My gosh. We talked about
that was compounding. So that's a little bit different than just buying a straight steroid injection. But the point in fact here is, because of the money from the NIH and because of the research there, we are able to take drugs like Avastin and go back and start new research on it. And like I said before, if it improves survival by 20-25%, you got 1,000 patients, you're looking at 200 to 250 patients that are alive with better survival and better quality of life. What is that worth? Can you put a price to that?
I think you bring up a really good point. Another question.
My recommendation is for everybody to get a hold of their congressman, to write a letter to them, and tell them to get their representatives off their butt and get this sequestration thing done and taken care of. If for no other reason for cancer research, that a lot of funding and a lot of jobs could be lost. Something else to bring up?
I have a question for you. Want to talk to you about everything I see in the books and the magazines and everything. Talk about that people are doing, that physicians use strategies to, look after their patients and fight the cancer. Do you look at yourself when you see a patient that has a cancer? Do you look at yourself as a strategist? Are you looking at that whole case and kind of figuring out your strategy a little bit on how you're going to do it, or do you just dive in there?
Both.
Both? Do you have to have a strategy to be an oncologist?
Initially, I didn't because I was ignorant. Okay? I was stupid. And then I found out...
Could I have a copy of this show, please?
And then I found out that there are a lot of people out there a lot more ignorant, a lot more stupid, and a lot less caring. And after so many years in practice, I realized that there are a lot of insurance companies out there that just don't give a damn about the patient. The bottom line is the dollar. And I'm sitting here fighting for my patients to get them treated, and I hear questions like, well, I don't think you should do that x-ray, or I don't think you should use that drug, or they got this pre-existing. We think it's pre-existing. I said, wait a minute. They just got diagnosed a week ago, and we got a Mediport in. We want to do the chemotherapy. There's nothing in their history of cancer a year ago that says, well, we're going to have to review
We're going to have
this.
to pen that. We're going to have to just hold that for a while.
They want to hold off doing anything for 30, 60 days. You try and say, what if this were your mother? What if this were your wife? You're going to delay. So over the years, you got to play these strategic games if you're going to fight for your patient. And I've just learned a lot of ways to do it.
Yeah, I would think that you would have to. And just be strategic, too, about when you're given chemo, and if it doesn't work here, what's my second? Do you always have a plan B in mind for a patient, I guess?
I've got all the way down to plan Z. It also depends on the patient. Don't make a mistake about this. There are patients that come hell or high water, they do not want to die. They want every treatment available. We recently had a patient who had brain mets, underwent whole brain radiation. She was an older woman, kind of knocked out from it, had bad lung capacity, went through the ICU. It was very challenging, extremely challenging, in that certain people and some doctors in the hospital just thought it was just relentless in trying to keep this lady alive, that they ought to stop everything and let her die. We eventually got it to the point that we stabilized her, got her over to another facility, and got a call from one of her daughters, and the mother is now sitting up. She's in a wheelchair. She's talking. Her swelling's gone away, and they're getting ready to move her to a long-term facility before moving her home. They're going to put a PEG tube in because she's got some swelling in her throat, but she moves her eyes, her head, arms, all extremities, and they've even got her up walking occasionally between parallel bars. So the answer to that is you just never know. You don't know what these people did not want to give up. We also have a young man who we're transfusing, has a very rare desmoplastic small cell, has gone through enormous amounts of therapy here in Dallas, down at MD Anderson. I believe he also went to Sloan Kettering, or the NCI, National Cancer Institute, to get an opinion. And there's just very little that can be done. And he just said, I don't want any more, but I don't want to die. And if I need transfusions every week, that's what I want. He's got good health insurance. He pays his premiums. He's 38 years old, and I see him every week. We check his blood work. And as aggressive as I am, I don't force the issue with him.
Let me ask you this. So he'll get blood transfusions. Will eventually the disease take its toll, or does he have
eventually the disease will spread.
But years and years, does he have years?
I don't know. This is one of 7 times I've seen this disease. And I've had patients who died within 2-3 months, and I've had patients who lived 2-3 years.
Okay.
So it's just it's a very
and he
rare...
always has that option to go and do chemotherapy.
Well, look, over a period of time, there are new drugs that come out, and I keep him abreast of everything new. His doctor down at MD Anderson is Dr. Ludwig, who I know, and we're both in communication with any new things. And the doctor here in Dallas, I know. So we're all. We know this young man. I mean, he's walking and talking, watching football. He's got children. It's not that he wants to die, but he's just worn out from all the treatment, from radiation, from chemotherapy.
And the doctor visits. Can you imagine?
Oh, my God.
It would just, it could wear on you. Going into the doctor's
offices. We're doing
offices.
it now where he just gets lab work, and they call me, and I say, look, Bill, you don't need to come in. We can just check your lab unless something seriously is happening. If you're getting bleeding or something because of your low platelets, we'll take care of it. We'll put you into the hospital overnight, give you the transfusion, you go home. But this is the way his life is right now. But everybody is going to be different in their approach to how you do it. And over time, you have to develop strategies for cancer patients. And it depends on what they want, not what the family wants, but you've got to deal with the patient as long as the patient's coherent and can make decisions for themselves.
Because you can overtreat a patient if you don't watch it, can't you?
Oh, in a heartbeat. In a heartbeat.
And sometimes the patient would rather, if they're saying, I don't care, I just want to fight the disease, they don't much care about the side effects. They just say, treat me, because the comfort of having chemo fighting the disease is better than doing nothing. And you have to kind of balance that, I would think, as an oncologist.
For me, because of the nature of what I do and being as aggressive and proactive as I am, is that you do run into problems when you're treating cancer patients and you're working in a community that is basically nihilistic. They're not aggressive. Is that you get other people in the community say, oh, he's just too aggressive. This is unnecessary treatment. This is cruel and unnecessary treatment to the family. And yet they don't know that the family wants it. The family has told me that's who I'm listening to. I'm not listening to the consultant on the case that I brought in, and I'm not listening to the nurse that they're saying this is cruel, unusual punishment. Why put them through all this? I'm listening to the family, whereas at the same time, if I personally think that there is absolutely no hope, that there's nothing else we can do in a certain circumstance, I will let the family know. Now, I'm not going to pull the plug on anybody. If the family wants more to do, I will tell them there's nothing I can do. I've reached my limit, and that's pretty rare, as you know.
Well, one of the things,
and I'll either get on the phone with the family there and talk to whatever their disease is, that department at MD Anderson or Sloan Kettering or Mayo Clinic, or where XYZ disease has been known to be heavily treated, where they did a lot of research, and we'll talk to them and let them know the case. Sometimes they'll want me to send the records. We'll immediately either scan them and email them or fax them to that place so that we don't have to waste a lot of time. If it's locally, then I'll send them to MD Anderson, or I'll send them here to Mary Crowley and get another opinion here if the family wants to go further.
Well, as a navigator, I try to teach people that you have choices. You have choices in who you go see as a physician. You have choices if you're not happy with your physician. I personally believe that we as a community, that we as consumers, that we need to show our hospitals and our physicians that we have a voice. We have a right to expect that your doctor sees you in a timely manner. We have a right to that your doctor's staff is friendly, is kind, does what they say they're going to do. We have that right. Patients have that right. And if we don't, we need to take our business elsewhere. And
no question about it.
Sometimes for somebody, it is not good for that patient and that family to be in a huge medical centers. Sometimes it is more in the community cancer settings. Sometimes they have more comfort at being in a large cancer center. But there are choices. I think what frustrates me sometimes is people think they're stuck in what they have to do. And if I could change anything about that is to tell patients, you have the voice. I had somebody this week who said to me, they were not your patient. It was not in your practice, but they were just kind of inquiring, and they said, I'm not happy where I'm at. Why? Well, the staff wasn't very friendly. I said, have you talked to the doctor? And they said, no. I said, you have a right. You've had a relationship with this person for 2 years, and you don't like his staff and how they're treating you, and you're not close enough to tell him? Well, I don't want him to be mad at me. I said, then you know what? Then you deserve to have the staff be mean to you. Because if the doctor doesn't know what his staff is doing, that's not the doctor's fault. He's bumping along thinking everything's fine, and his staff is ruining his business.
Is that any different? What we talk about, you may find that your second or third opinion should have been your first.
Absolutely.
People go to a doctor. They're at X hospital, and they live at that hospital that's in their community, and they trust their family doctor, and they come up with X cancer, and he recommends that this surgeon at their hospital do the surgery. And after the surgery, the surgeon says, well, I think you're going to need chemotherapy. I want you to go to this doctor. And it's true. It's a buddy-buddy system. It's been that way from the beginning of time. My point is that there are so many opinions out there that you need to get more than one opinion. I say it to the patient that I'm the first opinion. Get another opinion. You've got to feel comfortable that what you're going to do, because this is not a walk in the park. This is going to be tough. Chemotherapy's gotten better over the years, but it's still chemotherapy. Radiation with IMRT and IGRT has much, much better results and less toxicity, but it's still radiation. So you need to get opinions. If you feel comfortable, the doctor you're with makes you feel comfortable, and you feel secure what you're doing, then stick with where you're going.
I've always been proud of the fact that as a navigator, you know, the patient's right no matter what. I mean, the patient comes first no matter what. And it didn't matter to me whose door I was knocking down, because I was in it for the best of the patient. And, you know, I think that people, if you're in a situation where you don't have a patient navigator, you still need to find somebody who can navigate for yourself. And let's make the demands that you need excellent care. And let's make it a priority that you can get excellent care all across the board.
I think, and I've told you this a million times, I think your support groups are just, I can't even put a price on it, how valuable they are. What I also think that's very important is if you have a patient with colon cancer, look, I've taken care of colon cancer for 38 years now, counting MD Anderson. I like to send my patient to another colon cancer patient because they
or physician. You said patient.
I like to send my patient to another patient who had colon cancer so they can talk on the same disease.
I think that's really good.
And that patient can tell them, hey, I had to take chemo and this is what I went through.
Well, I think we're kind of wrapping it up. Thank you so much. I sure have loved being on the show. And I said goodbye last week. I love you all. And have a great weekend. Bye-bye.
Bye-bye, everybody. See you next week.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.